Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Welcome back to the OrthoZone podcast, presented to you by Tri-County Orthopedics. Today, we are so excited to have Dr. David Klein on this episode to talk all things broken bones. Welcome, Dr. Klein.
Thank you.
Before we start our discussion, Dr. Klein, can you tell the audience how you got into medicine and a little bit about your training?
All right, great. That's actually a great way to introduce this topic also, because the way I got introduced to orthopedics, like many, many other people, is by having an injury. People have sports injuries, people have automobile crashes and things, but I actually fell off the monkey bars when I was in third grade. I was trying to copy my sister by jumping off the platform on the monkey bars and getting to the fourth rung, where she got to the third. I was trying to get to the fourth, but of course I crashed and landed on the floor. I broke my left elbow and my right wrist at the same time. So since then, I just thought it was fascinating. I thought bones were interesting. I had to wear 2 casts. It was like a huge part of my life in third grade. And then that led me to just liking bones and the mechanics of bones in general. So after medical school, I was lucky enough to get into an orthopedic surgery residency, which was at Jersey City Medical Center. We treated all kinds of different things. In particular, we spent a lot of time doing fracture care. And afterwards, I did my fellowship at NYU in sports medicine, because besides for the sports medicine side, I still like treating fractures. I still like doing all the general orthopedic stuff. And the sports medicine fellowship allows you to do that. And the last thing that I did in training was present the research I did that year at the resident and fellow conference at the end of the year in front of the faculty at NYU, which was somewhat of a full circle, because where I got treated for both my broken bones in third grade was NYU Hospital for Joint Diseases. And that's the place where I did my presentation at the end. And I made it part of the presentation. It was kind of cute.
And then how did you end up here at Tri-County Orthopedics?
So during my residency, I spent a lot of time with Dr. Lombardi, Dr. Goldman, and Dr. D'Agostini at Morristown Medical Center. We had a trauma rotation, and during the downtime of trauma, I was spending time with the total joint guys at Morristown. I got to know them, and then the timing was right when I finished fellowship that they were looking for somebody to fill a role in the general orthopedic world / fractures, sports, and total joints.
And Dr. Klein, what do you specialize in here at Tri-County?
So my fellowship training, my official subspecialty would be sports medicine. But what I actually do, like the way I function, is I do hip, knee, and shoulder replacement. And I also end up doing a lot of the fracture care that comes in, because it's still something I find fascinating.
It was great to hear a little bit about your training. So, Dr. Klein, today's topic is fractures or broken bones, which many people don't realize are actually the same thing. And I know you often get asked, do I have a broken bone or do I have a fracture? Would you say these words are interchangeable? And can you talk to the audience a little bit about fractures versus broken bones?
Sure. So to an orthopedic surgeon, the word broken bone or fractured bone are entirely interchangeable. The place where it becomes confusing for patients is when you think of something as a fracture, you mostly think of it as a crack where something hasn't really changed its mechanics. It's just a small crack where the overall structure hasn't changed. And something that's broken is something that's broken or not working anymore, where the structure has changed. So whereas the orthopedic surgery world, we use the word fracture to mean anything that's broken, it's just confusing for patients. So we'll hear all the time, people will say, hey doc, is my bone broken or is it just fractured? Or alternatively, fracture sounds like a more medical word. So people will say, hey doc, is my bone fractured or is it just broken? And it's really interchangeable. The thing that we look at to differentiate different types of fractures or broken bones is whether or not the bone has shifted, meaning it's not in the anatomic place where it belongs. And that's what we'll describe as displacement versus not displaced.
So, Dr. Klein, how do you diagnose a fracture?
First thing that diagnoses a fracture for you is the patient's history. So given the type of injury they have, the description of how the injury happened should clue you in. And first step would then be x-rays. And x-rays, of course, are the first line and usually the only thing that you need to make your diagnosis.
What is your response to a patient who wants an additional MRI, even though the X-ray has told you everything you need to know?
Sometimes you do need further imaging. The most common type of further imaging that you would need for fractures would be a CT scan. A CT scan is really a three-dimensional X-ray. So when you're looking at x-rays, we'll always get at least 2 different views of the bone. So we'll look at it from the front and from the side so that we can, in our head, reconstruct a 3-dimensional view of what happened. But sometimes where you have one bone overlying another, or if you have, for example, in collarbone or in your shoulder where your ribs are also in the picture and they can be overlying what you're looking at, a CT scan helps you see a 3-dimensional view. And you can even use a CT scan to delete different bones from the image while you're looking at it so you can see things a little more clearly.
Really quickly, can you go over the difference between an MRI and a CT scan for some of our listeners who might not know the difference between those 2 types of scans?
Yeah, that's actually also another very common question that people will ask, like, why am I getting a CT? Why am I not getting an MRI? There's a very common conception that an MRI gives you the whole story or gives you the most story that you can get. Like an MRI gives you 3-dimensional view of the bones. It also gives you a 3-dimensional view of the soft tissue structures. So things like ligaments, things like muscles, things like tendons. An MRI takes a little bit longer to do than a CT scan and is more expensive. So we'll base our decision on CT versus MRI based on the statistical likelihood of different injuries. So for example, if you have a fracture on the top of your shin bone, or tibial plateau, there's actually a very high likelihood of also having a meniscus tear along with it. So if I'm going to be looking for 3-dimensional bone structure and also looking to see a soft tissue injury like a meniscus, I'll get an MRI. But in an example on a shoulder where soft tissue injury is pretty unlikely in the setting of a fracture, I'll order a CT scan because I'll be looking for 3-dimensional bone structure. I'm going to be looking to take measurements between the different fragments of bone that got displaced. And a CT scan actually gives you a better detailed picture of bone than an MRI does. So there are actually times where even though an MRI would theoretically give you more information, a CT gives you better information.
Why do some fractures need surgery while some need a cast?
So that's another very common question that people will ask. And people will ask, well, do I need surgery? Can I get away without surgery? And in general, a cast is going to be treatment for a fracture where the bone hasn't shifted at a place very far, where if you can use the cast to hold the bone in place as it heals and not let it shift any further, then that's all you'll need. And that's really the primary purpose of a cast, to hold things in place and let them heal. There are some things that we can do with a cast to push a bone into position, what we would call fracture reduction, meaning to push the bone back to where it belongs and then hold it in place, which you can use a cast for. And there are some limits to what a cast can do. Since a cast is outside your body and you have skin and muscle and ligament between the cast and the bone, you can't really push very accurately. You can push things in a general direction, but if there's something on the inside that you can't push from the outside and it's in a position where it won't heal well, or if it does heal in that position, the patient will still have pain or stiffness or weakness, that's where we would recommend surgery to open the bone, put it back in its anatomic position where it belongs, and then hold it in place with plates and screws or rods on the inside. And that's the general theme between casts and surgeries. And then there are other surgeries, or rather, there are other injuries where if you would treat it with a cast, the patient would get so debilitated by being in the cast that their function would never return. So in those patients, we'll do a surgery to allow them to start standing up right away. So if you have, God forbid, a hip fracture. Hip fractures are something that can be quite debilitating. In the olden days, you used to put people in bed for weeks until it would heal, which led to bed sores, increased chance of pneumonia, muscle wasting, and that's part of why hip fractures historically have a higher mortality rate, because people would have to stay in bed. But if you can fix a hip fracture, and we ideally fix hip fractures within 24 hours of them happening, we aim to get people out of bed within 24 hours of injury, get them up and standing right away so that you can minimize all those problems that are related to laying in bed.
Right. And that actually brings me to my next topic, which is weight bearing after fractures.
So with weight bearing after surgery, there are certain surgeries where our primary goal, the only thing that we, or not the only thing, but the main thing that we need patients to do is get up and stand up. so hip fractures. That's the primary goal of surgery, is to get people to be able to stand and weight bear right away. There are other kinds of surgeries where weight bearing is not critical, but it's very helpful. So for example, in ankle fractures, where historically, if you would treat an ankle fracture with surgery, a lot of people were keeping their patients non-weight bearing for 6 weeks and allow the bone to heal before getting their patients back up to standing and walking. Now, it's not entirely critical that you stand up and walk right after an ankle fracture, because ankle fractures by and large happen in younger patients who can handle using crutches. They can handle being sedentary without any major changes in their physiology. But with that said, if you don't walk for 6 weeks, even if you're in great shape, you'll still lose muscle tone, you'll still lose bone density. And if we can fix your ankle fracture in a way that allows you to stand up on it the following day, your recovery will be immensely accelerated. And in my own experience, in my residency, we used to keep people off of their ankle for 6 weeks. And they'd get out of their brace after 6 weeks, get them up and standing in the office and say, okay, 6 weeks has passed. Let's see how comfortable you are taking a few steps. And they'd look like a little chick that just hatched. They'd take a couple of little tentative steps. They're holding their hands out for balance. It looks like they're about to fall down. And you kind of have to encourage them and say, look, you're ready. Your bone's strong. Get up and stand. And it's mentally very challenging for people to start walking after they've been told, don't touch this for 6 weeks. Right. In contrast, now what I've been doing, and over the past 5 years, and this is something that we are looking to publish, is getting people up and standing on their ankle fractures the following day. There is some literature on this. There's literature with really, really good outcomes on this, which is why I started doing it. And I can tell you that patients come in 6 weeks after surgery after they've been walking, and I'll take them out of their brace and say, okay, now you can start walking in your regular shoes. And their response is, okay, great, I feel good. And they'll literally walk out of the office comfortable. They do a little bit of physical therapy because it kind of mentally helps you regain your confidence, but they really recover both physically and mentally much more quickly than having them non-weight. So in my mind, and this is also something that's in the general literature of orthopedics, early weight bearing is best for patients, early function is best for patients, and that's what I try to do.
Right. And I'm sure we could do a whole other episode on ankle fractures.
We can do 3 episodes on ankle fractures.
Right. That's all so interesting, and it kind of ties into my next question, which would be, I think our patients would be very interested in this. When you have a fracture in one part of your body, how does it have a ripple effect on other bones or joints within the body?
So it wouldn't necessarily have a direct effect, but it does tie into weight bearing and downtime. Right. So going back to the ankle fracture example, if you have an ankle fracture and that gets you on crutches for 6 weeks and you're holding your leg up in the air, classically the way you hold one foot up as you go around with crutches, your hip can start bothering you, your back will start bothering you. Your crutches, if they're a little too high, your shoulders will start bothering you. If they're a little too low, your back will start bothering you a little more. So it's all those things and all the body parts that have to kind of do a little bit more or hold themselves a little bit differently. And doing that for 6 weeks is where I see a lot of people getting the ripple effects, if you will, from fractures. But directly one bone directly impacting another one. Oh, actually, there is another way that things can get affected tangentially. So one of the things our bodies are really good at is adapting to stress. So if you work out a lot and you do a lot of weight-bearing exercise, your bones will actually get denser. Your bones will get stronger because of it. And if you don't do much exercise and you're sedentary, your body will respond by actually letting your bones become weaker. So if you do non-weight bearing for 3 months, you can actually develop osteopenia, meaning the density of your bone can decrease, which would put you at risk for fractures in your other bones, at least in the bones that are non-weight bearing. And we see that a lot. We'll see what's called disuse osteopenia if we have somebody non-weight bearing. And there are patients where, I like getting my ankle fractures up and standing right away, but there are patients that I'll have non-weight bearing for a few months. And for example, after a bad tibial plateau or the top of the shin, and you really have to keep them off of it to allow the bone to heal. When you get those x-rays at 3 months, when you're ready to let the patient stand on it, you'll actually be able to see on the x-ray that the bone is less dense.
That's super interesting. Some shorter questions for you. What is the most common fracture that you treat within your own practice?
Probably proximal humerus, meaning the top of the humerus bone.
Okay.
Or the shoulder.
I didn't expect that. I thought either hip fracture or ankle.
Oh, interesting. So I'd have to check the literature again, but the most common type of fragility fracture is actually a vertebral compression fracture, which I don't directly treat unless somebody comes in with one that I wasn't expecting. They'll usually go to our back specialists. But I believe the second most common is either the wrist, the distal radius, or the shoulder, the proximal humerus. And I'm pretty sure it's the shoulder. So I see a lot of those. I saw in the office today on a full office day, which was 40 patients, and some were follow-ups, some were new patients. I had, I think, 5. It was a good deal.
Then on the contrary, is there a fracture that you've treated that has been very rare?
So there are various types of elbow fractures that are more rare. I treat them because I like doing them and I've had good success with them. But elbow fracture dislocations, I'd say, are a little bit of a more rare bird that I treat.
So looking to the future, are there any emerging trends or research in the field of bone health or fracture prevention that might change the way we approach fractures in the future?
So I can't speak to the rheumatologic type things because there are some new things on the horizon and like different kinds of biologic medications that people are using to improve bone density. I have seen a little bit of that, but I don't prescribe it, so I don't really look at the research on it. The goal for medications like that would be to improve bone density without having the side effects that are traditionally related to the bisphosphonates, the drugs like Boniva, which have been very, very successful at improving bone density, but they do come with some very well-known side effects. So the goal would be to improve density and decrease fracture risk without having side effects like that. The other things that I try to do in my practice, everybody who has a fracture that I see, besides for recommendations of weight-bearing, surgery, casting, whatever, I'll also hand them a prescription for calcium and vitamin D and tell them to improve their protein intake and minimize or completely cut out nicotine use to the best of their ability so that they can not have their fracture slow down and be allowed to heal.
How does nicotine affect your bone health?
Nicotine affects, as you know, everything. And one of the things that's a little lesser known is nicotine will slow down fracture healing and at times can even arrest fracture healing, can even make a bone not heal. It does that because nicotine constricts the small blood vessels. So while constricting the small blood vessels doesn't directly lead to a medical condition, so to speak, restricting blood flow, especially to the periphery of the body, decreases nutritional flow and decreases the ability of the bone to get what it needs in order to heal.
One more question. Is there any future technology that could completely change the way we treat fractures that is going to come out in the next decade or so that you would know of?
I think that the one thing that's upending industries all over the place is AI. And I think once there is a little bit of technology available for augmented reality where you'd wear, let's say, an AR glasses, that the AR glasses allow you to see a 3-dimensional x-ray while you're looking at the patient, so that in the old days you used to have your film x-rays and you'd put them up on the light box in the OR as you're working so that you can refer to the x-rays while you're doing your work. Nowadays you can put up all the x-rays on a computer screen, you can put up all the CT scans on a computer screen, and you can refer to them while you're working. The next stage is augmented reality, where you could wear a pair of glasses that has a heads-up display, where you can look at the CT scan and you can even scroll through the CT scan, with different eye gestures or different eyebrow gestures while you're working. And then the next thing after that is going to be where you might have an AI assistant as you're scrolling through and as you're looking at the fracture, and the AI will have a camera built in that can look at the fracture while you're looking at the CT as you're changing its anatomy. While that sounds really super cool and interesting, it's also not very difficult to open a fracture, visually look at it, feel it, get everything lined up, check a regular x-ray while you're working, and make things perfect that way. So the AI sounds really cool. I don't think it's going to revolutionize what we do.
Right.
It might help what we do. The same way something like a robotic knee replacement hasn't revolutionized knee replacements, but it's another something in the toolbox to make your life a little easier.
Right. Well, I think that's all the time we have for today. I thought this episode was really interesting and you answered some really great questions. So thank you, Dr. Klein, for coming on.
Thanks for having me. Thanks for letting me go over all the common questions that people ask me, because as much as I try to explain things in detail to patients, after you've been asked something for the 1,000th time, and you develop a script in your brain, and you like say your script, and like at this point I could almost have a recording say all the things that I say when patients ask me these questions. But still, it's good to like sit down and go through it in detail, and if people listen to the podcast and learn something from it, then I'm happy.
Thanks again, Dr. Klein, for coming on. Stay tuned for next week. We are going to be kicking off a mini-series titled What It's Like to Be a Team Physician with Dr. Andrew Willis and Dr. Stephen Hunt. And the series will dive into their roles as team physicians for the New York Jets. It's going to be super interesting, so stay tuned for that, and we'll see you next week.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.